was designed and was defended by Dr. Serkan Sağır to evaluate the effects of forceps device in growing class 2 division 1 cases, so that we had the chance to see the results with our own eyes. Study comprised of 25 patients, growing class 2 patients with normal or mildly prognatic maxilla and retrognatic mandible, normal or low angle growth pattern. Let me show you the protocol through a patient, a case presentation. A typical class 2 patient, especially more remarkable on the lower facial third, retrostiff chin, extreme overjet, very deep overbite, class 2 dental relations. ANB value is about 9 degrees, and he is a low angle patient, 34 mandibular plane angle. That is right after leveling and alignment was finished. I mean, this is how protocol is progressing. You have to align the upper and lower teeth if you're planning to apply the fixed functional device to achieve the best skeletal response. You have to align the upper and lower teeth and then put the jumper or the forceps, whatever the fixed functional device, in place after putting the possible thickest wire in the slots. And here in this study, we also put some extra torque in the upper anterior region to avoid flattening of the incisors, which is probably very obvious. The picture is good enough. I don't know if you can see it. There's a little bit lingular torque here, not too much. You're not supposed to do that, but we were facing some kind of upper incisor retrusion. That's why we added this to the protocol. You can see the forceps was applied bilaterally, and this is after debonding, after removing the forceps device. The principle is, the rule is to bring dental relationship to a class 2-ish position. So this picture is taken a bit more later than we remove the forceps. You have to have class 2-ish, or let's call it super class 1 dental occlusion. Don't please remove any kind of fixed function devices in class 1 relation. Then you might have some disappointments. And as I told you, you have to place a TPA and a lingual arch in the lower to make sure that the force vectors do not rotate molars. This is right after debonding with a very nice overjet and overbite and nice full class 1 occlusion. His smile, his lips are in rest, nicely touching. Okay, this is the profile after debonding. The chin, you can see, is not too big, still not big, even though he was a low case. Before and after. Before and after. Well, this is the profile. You can see that the upper and lower lip contact now, no more strain and easy contact of the lips. And look at the labiomental here. He was having a lip trap, lower lip trap, because the extreme overjet after the correction of overjet and overbite. And usually you will see this improvement in this kind of protocols with the flattening of the labiomental fold. And if there is a good chin projection initially, then you will have a better result. But here, yeah, that's pretty good. Not bad, but not a very nice definition. So stephanometric records were taken before treatment, after leveling and aligning upper and lower arches, which is right before we place the forceps, and then following removal of forceps, which was about 6 months. So these results I will be talking about are the results of 6 months period. No effect on mandibular position, no growth was found in mandibular position. But still, sagittal-skeletal relationship improved, A and B decreased. Why? Because we found maxillary growth inhibition. Upper lip moved backward and nasolabial angle increased, probably following the maxillary growth inhibition effect. And for sure, because of this, convexity of the soft tissue profile was decreased. So looking at these results, I think it's better to use these kind of devices. Well, at least I can say about the forceps. Better to use forceps on maxillary protrusion cases, or if not, then to alveolar protrusion of upper anterior teeth together with retrusive mandible. Well, don't expect a chin definition because we couldn't find any effect on mandibular position. So case selection is important. If there is a chin definition before, we might have a better results. Here are some clinical remarks for case selection. These are from the forceps group. Well, the lips are apart because he can't close his lips, which is normal. It's a very severe class 2 with extreme overjet. And if you look at here, initially she has, even though he has a small chin, he has pretty good, well-defined chin. If you look at the picture after treatment, you can see that the lips are relaxed and contacting easily, and the groove here is flatter, and the chin looks better, and the nasolabial angle slightly increased. But on this patient, for example, there's no chin initially, it's a flat chin contour, and the mouth and lip apart position almost the same, overjet and deep bite almost the same, and after correction you can see that the lip contact is nice, but the chin definition, no, because we don't grow mandible with such devices. So if there's not a chin definition, you will not achieve a chin definition afterwards. These are 4 cases from forceps group. If you look at up here with a well-defined chin before treatment, the results are better in the upper line. If you look at down here, small chin, and after treatment, the occlusion just the same, very nice occlusion, but you can see that there's no chin projection. So fascial improvement is better in cases with pre-treatment chin projection. You have to keep this in mind. These are the ideas of the thesis defender as well. Well, I think we should always look at the new studies. I'm not going to bore you, but I have to mention this. I think this is an important study. This is from 2016. We can call it a new study, treatment effects produced by twin block versus forceps in growing class 2 patients. In conclusion, they said that twin block produced greater skeletal effects in terms of mandibular advancement and growth stimulation, while the forceps caused proclination of mandibular incisors. Well, I don't think it's that bad. I mean, for sure, almost all functional devices, removable or fixed ones, they all lead to proclination of mandibular incisors. But I know that there are some other changes acting on the upper arch and adding to the correction of the facial appearance with the fixed functional devices. Another study about dental skeletal effects of forceps device. This is a systematic review and meta-analysis. And what they are telling actually is forceps show positive effects dentally. However, there are some negative effects reported on the occlusal plane, and again, lower incisor proclination. Yeah, occlusal plane rotates posteriorly in all fixed functional devices. But this is a part of the correction, actually. This one is 2019, and it is a tomographic study. What they did is they applied forces on growing patients, and they evaluated the results, the efficiency of the forceps with CTs. And what they stated in conclusion is, Force presented similar results to other mandibular propulsion devices with dentoalveolar effects that favored class 2 correction. However, with very slight skeletal modifications, which I agree with. Well, let's talk about the advantages first. Well, possible to use during fixed treatment. Fixed functional devices except Hertz you can use during fixed treatment. There are some situations that you can align the lower arch, and you don't need to align the upper arch. If there is a lot of anterior crowding, you can attach directly to the upper first molars with a TPA for sure, and you can have more distalization effect, and then you can continue with the fixed mechanics in the upper arch as well. So it gives you a rapid correction of class 2 relationship without any limitation for oral functions. And it's a chair-side device, shorter treatment time, you don't pay for laboratory work. But I think the most important advantage here is it's independent from patient cooperation. Don't wait for the patient to wear the elastics or the headgear to correct the class 2. And the last but not least, it is easy to make stepwise advancement of mandible with fixed functional devices. So what? What does it mean? What is the difference between stepwise advancement of mandible to single advancement of mandible? This study published by Dr. Rabi and his friends, it's an experimental study. They experimented the stepwise advancements using fixed functional appliances on rats. What they found, the amount of bone formed in response to stepwise advancement was more than the single advancement. What they found, rats showed that stepwise advancement resulted in 100% more bone in glenoid fossa, 50% more bone in the condyle, which sounds very attractive. So stepwise advancement creating more bone, that's what they said. And a few years after, they evaluated the stepwise versus single step advancements in patients with a clinical study. And they found the amount of correction resulting from skeletal changes was greater in the stepwise group compared to single advancement group. They also evaluated the effects of stepwise advancement of Hertz lines, and they compared it to mandibular sagittal split osteotomy, orthodontic surgery. And they stated that Hertz lines with stepwise protocol is an available option for correcting borderline skeletal class 2 malocclusion in adult patients, which gives another question, which brings us to another question to answer. Okay, if they're advising to use this on, well, average class 2s in adulthood, what's going to happen to TMJ? Does TMJ like this kind of protocol? This is a prospective longitudinal study, clinical study and MRI study of Hertz patients carried out by Sabine Ruf and Hans Panches. In the short term, which means before treatment to 1 year after treatment, they said that bike jumping using the Hertz does not have a deleterious effect on TMJ function and does not induce any temporomandibular dysfunction on a short-term basis. Another study in 2009, again an MRI study, also a short-term, 12 months. Idar et al. Said that Hertz therapy does not cause adverse effects on the morphology and position of the articular disc. Another one, this time a systematic review, and they could pick only 12 articles, and they said that the selected articles failed to create any evidence about this. They don't know what's happening in TMJ. They cannot conclude anything. And another study, 2015, this time from Dr. Panchers and his colleagues, silent symptoms of TMJ disorders in adults after adolescent Hertz therapy. How much after? 6 years after and 13 years after, they took radiography and clinical examination and anamnestics. What they used for radiograph, CBCTs. And the conclusion was there were few cases having some clickings and blah, blah, but he said that herbs treatment corresponded to those in general population. I mean, the problems with the herbs treatment appearing 32 years after corresponded to those in general population, not more than that. And thus, they conclude that in the very long term, the herbs declines does not appear to be harmful to TMJ. This is the only and the longest follow-up study about TMJ after herbs decline, which is a rigid device. Rigid mandibular advancer. And this one is a retrospective study. They evaluated two groups. One group was treated in pubertal stage. The other group was treated in the pre-pubertal stage with herbs declines. And then after treatment, which is not so long, it's also a short term, regardless the stage of skeletal maturation, herbs did not change condyle post-op relationship. So you decide what happens to TMJ. Well, I believe that we need a lot more studies, and preferably, I would like to see these adult group treated with herbs declines, and let's say after 10 to 20 years, what happened to their joints. Maybe it could be a lot better if we could make it a longitudinal study. Here are the problems of fixed functional appliances. They are mostly tooth-anchored, so severe average loss. Lower incisor proclination, which leads to relapse after treatment and for sure crowding. Lower incisor proclination also creates another problem once you procline lower incisors due to position of the fixed functional device. They move forward, that's why you cannot advance mandible more. So it limits forward movements, forward activation of the mandibular position. So you have more dental, less skeletal correction. You camouflage the problem very fast if you don't take precautions. And for sure, if you allow these incisors to procline a lot, there will be a risk for gingival recession on the buccal side. Especially if there's a thin biotype initially, you have to be very careful. Can we control proclination of lower incisors? I will give you a few things, tips and tricks about it. First of all, using segmented technique for incisor uprighting and intrusion before you start with the fixed functional devices. Let's talk about that with a case. The best way is to show is the case. This is a female patient, 15 years, 5 months, which we can consider as pretty old for a functional device. But, you know, after all, they're old and all correction, so we are using them. She's actually a young adult. You can see that she can hardly close her lips because of the intraoral situation, we will see now. And the profile, you can see this contraction here. Lips are tense when she tries to close. And this is the intraoral situation, class 2. Overjet is 10 millimeter and overbite is 6 millimeter. And she's, her radius almost fused. She's becoming an adult soon. Here is the skeletal pattern. You can see that she's skeletal class 2 due to mandibular tugnatism. She's on the high angle end of the scala vertically. And we have to pay attention to IMPA is 93, not too bad for a class 2 case because there's a little bit camouflage of class 2s, so incisor can be slightly proclined, lower incisor. But still, we don't want to increase it. We want to advance mandible forward by jumping device. So we need that overjet, just like in surgery cases. We have to control the dental movements. So in such a case, look at the occlusal plane in the molar region and look at the occlusal plane in the incisor region in the lower arch. Big step here. Probably she's having a very steep curve of speed. So if you put continuous arch wires in such a patient, you will automatically procline lower incisors and you will not we will not have any overjet left to protrude the mandible. It is better to use segmented technique in such cases before you start protruding mandible. You have to align the teeth in the lower arch with segmental technique. So posterior wires separate from the anterior leveling wires, three-piece alignment. And then after aligning the front teeth, taking the posterior segments as anchorage, you can use intrusion arches. And here the protocol is Burston. Now I will show you that. Always keep in mind this protocol, this principle that you have to correct the overbite before the overjet, which means you have to correct the deep bite problem, not to hit upper incisors before you carry the mandible forward. So how do you make intrusion without proclination? Burston. Burston is the best protocol. So you have to apply the force with such an approach. If you apply the force here, intrusion force is here, then the force goes through the center of resistance of the anterior teeth, the root teeth, and then you can achieve an intrusion, pure intrusion, without proclination, but you have to be very light. Light forces should be acting on incisors because they have very tiny roots, you know. And here you can see that the alignment, incisor intrusion was achieved, and then now you can switch to continuous wires without any fear to procline incisors more. This is after alignment was correct, it was finished, and the thickest possible wires were inserted in the slots. In this case, it's 1725 SS wires, TPA in the upper for rotation control, and lingual arch in the lower, again for mobile rotation control. And for sure, I'm talking about 18 slots here. Before treatment and after, leveling and alignment was fully completed. Now we can place the bite jumper. This time bite jumper is bite corrector. You can see that it was attached to the same place like forceps behind the canine and to the upper molar. Bilateral bite corrector was inserted to step mandible forward. This is how she looks like when the system is in the mouth, and obviously the force vectors are all the same, just like herbs and forces and jumper. Bite corrector is something like this. You can see that there are two cylinders with nickel titanium coils inside, and when the patient closes, these coils are pushing the sticks outside, and which means the mandible is moving forward by leaning towards the upper molars and the upper dental arch system. And that's where after treatment, very nice profile, acceptable profile. I mean, this is, after all, this is not a surgery. I think she looks nice, very nice smile. And before and after, and this is the situation, after. You can see that it's a full class 1 occlusion, nice overjet and overbite. And what happened here is upper dental arch drifted distally, while lower dental arch drifted mesially, upper incisors retroclined, lower incisors proclined, which impossible to control. We will talk about it. Pre-treatment, that she was having contraction, lip contraction, and with the device in the mouth, patient may ask you if the child will turn out to be like that, protrusive like claustry. Yeah, well, you all know that you should say no, it's not going to happen. We are not having so much progress, unfortunately. But in the post-treatment, you can see a very nice contact of the lips without any contraction. Before and after, before and after. And the profile changed like this. And the second control method may be using mini screws. Mini screws can be used to avoid lower incisor protrusion. Is it so? We wanted to try it, so with one of my assistants, we decided to apply mini screw while using the fixed functional device. The patient is hardly closing lips. She's presenting lip crack. We can see that the incisors are protruded. And this is the intraoral situation, pretty large object and deep bite. And she is well, in a very strange situation. I mean, she's growing, not much left. She's almost young, she's almost adult. If you look at the vertebra here, there's not much hope. So this will be a dental alveolar correction device. But here the target is can be controlled with over incisor proclination. We are not really demanding mandibular growth. She's presenting a slightly high angle vertical growth pattern, class 2. Increased upper incisor inclinations. Lower incisor is not that bad, it's 90 degrees, but we won't control it. We started with expansion, rapid expansion in the upper jaw. In the meantime, we didn't want to waste time, so we are leveling the upper front teeth from 3 to 3. We put brackets and wires. And while we are leveling the lower teeth, because you can start without leveling upper, but you cannot start without leveling lower teeth because you will cause more incisor proclination if you do so. So you have to align the lower teeth and make sure that you put the thickest possible wire in the slots before you insert any bite jumping device. After leveling and alignment was completed, we put mini screws between 5 and 6 in the lower arch on both sides, and ligated 4s and 3s, lower 4s and 3s to the mini screw. And every time she came back, which is about 6 weeks, we were tightening the ligatures because they're getting loose. We were tightening ligatures. She had TPA for sure after expansion to control, and then she had forceps bilaterally inserted together with the mini screws to control the incisor proclination. That's right after we removed forceps. Then we switched to the brackets to complete the treatment, but she was not brushing well. You can see from the gingiva. Oral hygiene was not good. She had some white spot lesion, so we hurried out the bonding. This is the situation after treatment. I mean, this is what we could achieve the best. And the face was good, lip contact was good, smile. And her profile seems that we don't have much change. The lower facial turf still looks a little bit retrusive, but for sure, smile is better. And let's see what happened to lower incisor, which was our target. IMPA moved from 90 to 98. Well, I can tell you that there are values changing from 5.7 to 14 degrees of incisor proclination. I'm talking about the differences for sure of IMPA. Well, 8 degrees, well, not good, not bad, so bad, but not good. But even with the mini screws, we didn't achieve a good control on lower incisors. Somebody else tried it, and we didn't have a study, but they had a study with that. They applied this acrylic splint first in the lower arch. The protocol was a splint in the lower arch, and they attached, they put buttons on lower trees, and then they put elastic chains from the mini screws to these to the lower canines, and the mini screws were placed between 4 and 5. And in conclusion of the study, they said that anchorage to mini screws with elastic chains increased the orthopedic effect of the acrylic splint herbs appliance. It has been confirmed that skeletal anchorage reduces incisor flaring. They said that they could control incisor positions, so they could advance, they could protrude mandible forward more, since there is no camouflage of lower incisors, so they could increase the orthopedic effect. And another study, this time, this is a very new one, it's 2019, they put mini plates in the lower anterior wall of symphysis, and they attached forceps to the mini plates. And what they found is using these mini plates were successful in increasing effective mandibular length. They created more mandibular protrusion in class 2 malocclusion in the short term. That's what they concluded. This reminded me a study which was carried out, a PhD study which was carried out at the University of Marmara in 2003. It was a thesis which was supervised by my teacher, Dr. Erverdi. And he put these mini plates about 13 years ago. Yeah, sorry, it was 2007. So he put these mini plates 13 years ago with the same protocol, but we didn't find any mandibular lengthening. Well, honestly, I remember it because then it became a book chapter. So I was involved, and as I very clearly remember that we could achieve it. There was a good control on lower incisors for sure, because it's not dental anchorage, it's skeletal anchorage, but we could have some maxillary restriction, drifting of the upper teeth distally, but we did not achieve any elongation of the mandible. So I believe that we need to have more studies about that. I can believe that the incisors will not flare forward with this kind of protocols. Maybe mini screws can control incisor positions, but I'm not sure about the mandibular lengthening. Needs a lot more study, I believe. So, summary of the webinar. Looking at the studies, not my study, but all other studies published, not all of them, some of them, Hertz cause more mandibular growth than untreated class 2 controls in growing children. So you might have longer mandible with Herbst. Herbst was reported as efficient to improve soft tissue profile also on young adults, I mean older patients. There is no agreement about the skeletal effects of other fixed functional devices in growing children. Not enough study, not enough well-documented material. But all these studies agree that all these fixed functional devices successfully correct class 2 occlusion, but mostly dentally. And all agree that they lead to improvement of the soft tissue profile. Because when we change the incisor positions, when we upright upper incisors, we relax upper lip. When we procline lower incisors, the labiomental fold is flatter, and the lips contact easier because we correct the overjet and overbite. All of these together creating a better and more relaxed lower facial third. That's why there is an improvement of the soft tissue profile, which is welcome, I believe. All devices cause lower incisor proclination, and mini screws should be considered while treatment protocol, while planning treatment protocol. Maybe we have to design better mini screw applications. So, shortly, the indications for bite jumping devices, class 2 cases characterized by mandibular retrognatism with slight maxillary prognathism or with slightly prognatic incisors, upper incisors. Normal or lowing vertical growth model, preferably. Active growth, preferably peak, and you have to monitor during the post-peak. And if possible, you have to select cases with retrusive lower incisors, or you have to control the lower incisors while aligning the teeth. And for sure, you should always have clinical and sabermetric evaluation before you start. If you expect better improvement on the profile of your patients, you better select cases with good chin definition before treatment, and please treat them in peak, so you have to check their growth stage. And now you can use cervical right there, where you don't need to take hand risks. And after treating in peak, you have to monitor them until the end of post-peak. And during treatment, please avoid lower incisor protrusion. Try to level after incisor intrusion, or try to upright incisors, maybe with some stripping. And you can choose stepwise advancement according to literature. It sounds beneficial. And you have to continue the treatment, the correction of the occlusion until super class 1, class 3-ish. And make sure that you finish the treatment with good interdigitation, which I believe is very safe for long-term follow-up. I want to thank to all my colleagues and my friends for their nice contribution, great contribution to this webinar with their cases and their efforts. And I want to thank you all for this very kind attention. I hope you are not bored. And I want to finish with a nice view from Istanbul. Thank you. Federico, I'm done.